I think the future of orthobiologics is absolutely unbelievable. But we don't quite understand why they work, where they work. So you have a lot of charlatans out there promoting stem cells for things they may or may not do. So we have a bald knee. We have a knee that needs a knee replacement. It has no cartilage in it, just like a head has no hair. So if somebody comes by, a rep in the office, and has a bowl of cream and calls it stem cells, how many people would pay $5,000 and say, rub it on your head and expect hair to grow tomorrow? Probably not too many, but that's what's happening out there right now. I think the future is unbelievable, but there's a lot of charlatans, and people are willing to pay $5,000 out of their pocket. They complain about a $20 copay to see Dr. Lucchetti, and he's worth 30. I don't care what you say. He's worth 30. He's not 20. So, but this $5,000, they will take $5,000 because they want to avoid surgery. But it's just not there. You can't inject this stuff into the knee, expect it to grow cartilage. It's not there. The only way it'll help is if you have a wallet and you take $5,000 off, so you weigh less, and then there'll be less pressure on your knee. So that's about the only value. So we're here because this is a health and wellness seminar. I was thinking about this last night. And what if it was called the Sickness and Illness Seminar? How many people would come? Probably not many, you know. But that's what we're here for. We want to avoid sickness and illness. So I could avoid all my slides and go right to the conclusion. I think that's what I'm going to do. So really, if you want to stay healthy and well, the two take-home points today are stay out of hospitals and stay away from doctors and prescriptions. You will stay much more healthy, and the statistics show that, okay? Hospital and medical-related errors are the third leading cause of death in this country. 400,000 people. Now, if you're sick, you need it. But most people that come to Wayne and I, they're not sick. They have a sore shoulder, a sore hip, or a sore knee. They're not sick. You don't need to be in a hospital. And how about prescriptions? Do you know how many people come in with polypharmacy, and that means they're on 20 different prescriptions? It's unbelievable. Probably they don't need a lot of those, and the rule with prescriptions is you should be on the lowest amount for the shortest amount of time, most of the time. But you just get one because you think it's appropriate. Look at this. So prescriptions are the fourth leading cause of death in this country, side effects of prescriptions. How many people knew that? Everybody here is afraid of a heart attack or stroke. How many people are afraid of dying of the side effects of prescription drugs? But it's true. It's true. So, you know, a lot of the advances in knees are not that great over the last 20 or 30 years. You know, Wayne was talking about the hinge joint we put in there. The metallic properties aren't a whole lot different. I could take a knee from 25 years ago and put it in and pretty much get the same result of the knees that they have today. The technical advances aren't that much. The advances that we have are in tissue management, pain control, how we treat the patient. That's really what I'm going to concentrate on here. So, the opioid crisis, I call it the 5 Ps. Everybody has some blame there. Physicians are perhaps tied at the top of the list with pharmaceutical companies to cause this problem, and I'll show you why. Payers, patients, politicians. We could add a 6P, probably police are in there. But these are responsible. So if that's the case, and we're partly responsible, you know what? Then maybe we should be part of the solution. I'm sort of going to go over that with you. So we're the silent gateway to this problem because 80% of all the addiction problems start with our prescriptions. If you look at this, these are millennials. 18% of millennial women went on to persistent opioid use after surgery. 18% became addicted. And women are more likely than men to become persistent users or to be addicted. If you look at it, women are prescribed more opioids than men, and they're prescribed 15% more. It's just reality for whatever reason. 1 in 4 orthopedic surgical patients were prescribed a daily dose of opioids equal to 90 milligrams of morphine. This is what they go home with. This is the history. If you look at this, 20% of surgical patients admit to refilling their opioid prescriptions even though they don't need it. They just want it at home just in case. Okay? And 90% of them have extra opioids at home, and they're accessible to family, friends, they've admitted to. So this is part of the issue. Look at this, the average knee replacement. The average knee replacement goes home with 130 oxycodone, Vicodin, Percocet prescriptions. That's crazy. You know what we give now with our new multimodal pain approaches? 10 to 15, let's say 13, 1/10 of that. 1/10 of that. So it's absolutely amazing. And if you look at these surgeries, zero in on the hip and knee. So between 10 and 15% of our surgical patients become chronic narcotic users. That's our fault. That's our fault. It's our fault. So anyway, but they're the historic gold standard. This is all we knew when we trained. All we knew was how to use opioids. We had no other tools in our toolbox. But look at the side effects. There's 24 side effects: nausea, urinary retention, constipation, decreased breathing. And so we need an alternative game plan. We just can't stop it, or else we'll go back to the old days of Samuel Gross. This was our historic post-operative pain protocol. We operate and we gave you narcotics. That's all we did. Look what we're doing. Look what we're doing now. Now we have something called preemptive analgesia. Now this didn't start until 1993. That was the first article on preemptive multimodal analgesia. The average age of an orthopedic surgeon in this country is 56. If you do the math, half of the orthopedic surgeons in this country graduated before the first article on multimodal pain relief came out. So you wonder why they're prescribing 130 Percocet after surgeries, because they weren't trained. So this is what it was, but look what it is now. Now we start, and I'll go over, 30 days ahead of time, we know about supplements. We know about nutraceuticals that decrease pain and inflammation. We start a month ahead of time. The day before, we load patients with non-narcotic medications. The day of surgery, before surgery, we have 4 or 5 other non-narcotic medications. Not everybody does this. Look at that list that we start before we even start the surgery. In surgery, during surgery, we have a bunch of other medications that we go over. And post-op, we put people on around-the-clock non-narcotic pain pills. And look what happened to the oxycodone. It drifted all the way to the bottom. It's all the way to the bottom, and it's only there for breakthrough pain with those 10 or 13 pills, not 130 pills. I was out to dinner the other night with my neighbor who reiterated a story when he had his wisdom teeth out when he was 20 and had 100 Percocet to go home with. And he went home and he was diligent in taking every one of them. He laid there in bed for 3 weeks and just took them. And he got addicted to it. He had to go into withdrawal, and this is what happens. So I look at this as preparing for a test or preparing for a race. If you do your homework and you do your training, when you show up for your test, it's just a formality. You know what it is. When you show up for that marathon and you've done 4 months of training, you're going to do great. But if you show up and you didn't train, or you didn't study, you're going to fail the test, you're going to do terrible in that race. That's the same thing that happens in surgery. If you're not prepared and do all this stuff, you're going to wake up, you're going to have tremendous pain, they're going to give you opioids. If you do all the preparation, it's absolutely amazing how little pain you have post-operatively. So here's what a multimodal pain approach. All those medications we talked about work at different parts of the pain pathway. And so some work at the incision, some work at the nerves, some work at the spinal cord, some work at the brain. But if you look at the top right, this is how orthopedics think of this. The pain message is that what gets to the brain, or the water coming out the end of a hose. So if you don't do anything, that pain signal is going to inundate the brain. If you step on that hose, it might dampen that water or that pain signal. But if you have 6 people stepping on that hose, which are all the different medications, there's no pain signals that get to the brain that need opioids. So that's the logic behind layering this stuff. I'll kind of go over that with you a little bit. So all pain comes from chemical inflammatory mediators. When you get cut, when we make an incision, there's chemical mediators that's at the level of the cells that stimulate a pain signal to go up. So if we could decrease those signals before the incision, you're going to have less pain afterwards. So here's a list that I give to patients, and that list is in the back. You don't have to remember this. You can pick up a handout on the way out. But when patients come in and they say, well, I can't take anti-inflammatories, I have an ulcer, I've had gastric bypass surgery, I'm on blood thinners, what else can I take? And what they take is they get a prescription for Percocet or Vicodin or oxycodone. I give them this handout and say, here's 25 different things that you can take that will lower that inflammation. And a lot of you have heard about a couple of these. I'm not going to go through the whole list, but I'll give you an idea. There's more evidence-based science behind omega-3s and fish oil than any other supplements. The only supplement ever recommended by the American Heart Association, because it not only reduces cardiac mortality, mortality is death, but all-cause mortality. So why wouldn't you take this? But yet we're still called the night before at some of these hospitals that say, stop your baby aspirin, stop your fish oil. We're stopping these things that not only decreases inflammation, but it decreases your stroke, a chance of an MI, arrhythmias, platelet clumping, clotting, DVTs, pulmonary. Why would you stop this stuff? Those are things we don't want to happen post-operatively, right? So another thing you probably never even heard of, L-arginine. L-arginine combined with omega-3. Anybody that trained like Wayne and I did in an intensive care unit, spent time in a burn unit and a trauma unit, all of the nutrition that you give these patients has two substances in it. Omega-3, which is fish oil, or L-arginine. Why? Because together they work synergistically to decrease the infection rate. This is proven in wound care, everybody in wound care, and it allows the incisions to heal better. Why wouldn't we give this to our patients? How many people ever had surgery and their doc said take L-arginine or fish oil because you're going to have lower chance? But this is science. We're not making this stuff up. And do you think Nestle and Abbott haven't figured this out? These are immunonutritions drinks that they promote to cancer patients. Any surgical patient that says take these drinks before surgery, the month ahead of surgery, and look what's in them. All that's in them is fish oil, L-arginine, some protein, and water. So these companies aren't silly. So you don't have to get this. So we put all of our patients on L-arginine and fish oil a month ahead of time. So these are wonderful, easy things that don't have the side effects that you ought to be doing. Turmeric. How many people have heard of turmeric? Yeah. How many people that have heard of turmeric were put on it by their physicians? Ah. This has been around for 5,000 years, right? Modern humans have been around for 50,000 years. That's 1/10 of the time that humans have been on this earth. Humans are not stupid. They figured out that this works. They don't know how it works, but it worked. And look what it does. Modern research now, it's like aspirin. We used aspirin for years before we knew how it worked, but now we know how it works. Same thing with turmeric. We know it works because it's an antioxidant, has anti-cancer properties, has antibiotic properties, has antiviral properties, and it's 5 to 8 times as strong as vitamin C and vitamin E. Why wouldn't you try this? It tastes terrible, but now it comes in capsules. This is another thing. So why is your doctor more likely to give you a prescription? Well, because 70% of us are on that and are on one of them, 50% are on two, and I can't tell you, I think half our patients are on 10 of them. I think half our patients are on 10 of them. And the most common ones, opioids and antidepressants. I'll just regress because I like regressing. I like history. So why does this happen? Because 100 years ago, the titans of industry, Rockefeller and Carnegie, were well invested. People think that they were in the banking and the railroad industry. They were in the drug industry. Petrochemicals, right? So they commissioned the Flexner Report, 1910, over 100 years ago, to shut down half of all the medical schools in the country. They said there's too many medical schools. There was 150. They shut down 75 of them. And they said, we will fund these under the auspices that we change the curriculum. And we take everything out of the curriculum that has to do with diet, plants, herbs, and vitamins. because they have no role. Everything has to be pharmaceutical based. So that is why allopathic medicine is pharmaceutical based 100 years ago. Now there's some good things about that. They came up with the scientific principles and we start studying them, but really their impetus was to preserve their industry. So that's really why we had a year of pharmaceutical training, but we had about an hour of supplements, okay? Had an hour of supplements. So the other thing, why can't we get hemp-based CBD, the active ingredient in marijuana, but hemp-based, because it's a wonderful, wonderful chemical. I'll talk about that a little later. It's the same thing. So these guys in 1937, they controlled the paper industry, the petroleum industry, and hemp, not marijuana, would compete with them. So, and they were part of the opium cartel. So they got that sanctioned as a level 1 drug. It's absolutely crazy. Another medication, this has been around for 5,000 years, like turmeric, but we can't use it. So it's going to be a blip in history between 1937 and 2018 where it's now becoming legal because we could do some research on it, okay? There was a vitaminologist, whoever knew there was such a thing. So this was in the 40s, right? This was after Rockefeller was giving all this money to the allopathic medical schools. And he was saying, you know what? The farming isn't that great. Almost the beginning of organic farming, okay? And he said, maybe we should look at supplements like B vitamins, wheat germ. The soil was depleted of nutrients. And you know what the FDA did? They prosecuted him. 10 docs of the American Medical Association testified against him. And they said vitamins are not necessary for the human body. It's 1948. Many people were probably born 1948. And so he was found guilty and he was fined the equivalent of $25,000. Okay, so this is crazy when you look at the history. And so then the FDA helped and they said, we're going to define a supplement as something that it can't treat, cure, prevent, or diagnose a disease. So you can use it, but we can't call it that, okay? Can't call it that. And why? Is because it costs, millions and millions of dollars to get a drug approved, and most of that funding is a source of funding for the FDA. So they don't want to approve something. But here's the sort of home run. Do you know how many drugs come from plants and herbs?
Most of them.
Most of them, right? So pharmaceutical companies isn't crazy. Think of them, right? Think of aspirin, digitalis, metformin, almost every antibiotic, okay, vincristine, cancer drugs, all of these things, cortisone, morphine, pain med, all of it comes. So what did they do? So pharma can't patent nature, and they have no interest in natural cures, so they copy or they slightly modify them, then they patent them, they market the pill as a wonder drug, and then they call the original plant worthless. This is what happens in the world. So guess what type of medicine Rockefeller, his family, and the British family still use? Homeopathy. So it's sort of interesting just to look at the history. It's not all bad, but it is sort of interesting to look at that. So this is why I always cringe when we sort of talk about supplements and I go, oh, thanks, Dr. Meade, I'm going to go talk to my family doc. And I just go, ugh. I go, because it's a crapshoot. He may know nothing about it, but everybody thinks that, the family docs, their internists are omnipotent. They're really not. They didn't learn about it. And unless they have an interest in it, they're not going to be able to sort of inform you. So look what's happening, right? Look what's happening 100 years later. The tide is turned, okay? The biggest gift ever to a medical school, $200 million. UC Irving last year. What was that for? It was for the implementation and studying of alternative medicine, supplements, and nutraceuticals. Look what traditional medicine did. Guy from Yale, this is a massive failure of academia. This should be the final line that doesn't get crossed. This is crazy. Doctors should avoid medical schools where integrative medical courses are required. If you want to use your time productively, don't take classes where you're not going to learn anything that helps you make. These are from the academic centers. And so look what happened 100 years later. Somebody with money, like Rockefeller, is changing this. So this will come full circle. So now we're going to be able to research. We never had the money. If you don't have the money, they're just going to poo-poo it. So it's pretty interesting. So anyway, let's go back to where I got carried away there for a second, but I like getting carried away. So here is our toolbox. These are all the things that we use now to avoid narcotics, which are good for acute pain. Don't get me wrong, you get your foot run over by a train today, it's very good for a week or so. But you know what the problem is? Chronic pain. We now know. We've done a disservice. Does this make sense? People on chronic opioids have more pain. It magnifies their pain. People that come in, I've been on opioids for 10 years for my back pain. Well, it was a self-propagating issue where it's called neuroplasticity, your neurologic system changes, and you have more pain. And it's often hard to get them off it because now their neurons, their synapses have changed. So going forward, we could avoid that. A lot of patients don't like that. But here our anesthesia colleagues were a lot smarter than we were. This a couple of years ago, they said every surgical patient should be on nonsteroidals, acetaminophen, and a neuroleptic like Lyrica or gabapentin, unless it's contraindicated. And it hits that neural pathway at several layers, so you don't need the opioids. But how many people have a knee scope? They have ENT surgery, they have urologic surgery, you still get the narcotics. Because they say stop the anti-inflammatory, stop this, it's going to cause bleeding, etc. And a lot of that is not based in fact. How many people say Advil doesn't help me, Aleve doesn't help me? You know what I say? You don't know the dosages. You don't know the dosages. So I go, I take 2 Advil, doesn't help me. I go, you know what? Before it went over the counter, the prescription was 800. So do the math. That's 4 of those little pills. Now you should still take it for the shortest amount of time, but if you take real doses, the best over-the-counter remedy is you go take 4 ibuprofen, 4 Advil, 2 extra strength Tylenol. They go, oh my God, that's 6 pills. But they'll go home and take an oxycodone. They'll take an oxycodone, right? So you take this, as long as you take it for a short period of time. You could do that 3 times a day. That's 18 pills. Oh, 18 pills. Well, they don't know the math. They don't know the math. So if you get them over that, that's the morphine equivalent of 6 to 8 of morphine in a day without the euphoric effects. And they go, so we do this before surgery. You know how many people come in for knee surgery and they go, Doc, do I need my knee done today? Yesterday I took all that medicine. It feels great. I go, well, of course it does. You just can't do that long term. But that's sort of the secret of understanding multimodal pain approach. And here's a game changer. It's another controversial thing. As you can see, I like controversial things. Okay, so this is a medication that came out a couple of years ago. It's a longer-acting Novocaine. When the dentist gives you Novocaine, it lasts 2 hours. They have a new Novocaine that lasts 2 days, 2 to 3 days. And we put it in the knee, but there's a couple early studies that were poorly done. Pharmaceutical companies didn't like it. They said it doesn't work. But if you do it right, and it's been proven now in 16 large centers, this is a game changer. Only Coordinated Health can use this because it costs a little more, not a whole lot more, but it allows us to get people home. But the big hospital networks where I work at, they won't even approve this, but they will approve 120 oxycodone to go home with. Right? So, and we do have other tissue-sparing effects. So we are a lot better, like Wayne showed that incision. So even though that looked like a formidable incision, it's a lot smaller than it was years ago. We're efficient. You don't want to spend 2 hours in the OR. We use a short tourniquet time. We have other really cool medications which stop the bleeding. We don't type and cross people anymore. Remember the old days you had to give your blood? I mean, it was like a bloodletting, Now we don't do any of that stuff. So, and the driving forces, have been outpatient arthroplasty. Why is that? Because it costs too much money. We can't afford to take all these healthy people. You're not sick. You don't need to be in a sick place. So we can't afford it. So if we're going to send you home, we better make sure that you're not calling Wayne at 2 in the morning asking for more Percocet. And he goes, no, Dr. Meade said I can't give this. So go take some vitamins. So anyway, why would we do this? And so the modern knee replacement, I hate the word knee replacement. Okay, if we replace your hip, we replace your hip. We replace your shoulder, replace your shoulder. If we replace your knee, we don't replace your knee. Now, why do we call it that? I don't know. It confuses patients. Confuse them. We replace the cartilage or we resurface it. Think of us like a dentist now of the knee. So we take off minimal bone and we put these caps on there, and it confuses people. Is that a partial knee? No, a partial knee is a half of a knee. But even our total knee is like a resurfacing. So that's sort of just a clarification, if you will. So all these cases used to be done as an inpatient, okay? Partial knee, spine. Now they're all done as an outpatient. So why not joint replacements? So two-thirds of all the humans who have ever lived in the last 50,000 years, over 65, are alive now. So, that's good, I guess. But their parts wear out. 1900, the average life expectancy was 45. We've doubled the life expectancy in 100 years. So, and we have 12,000 people a day joining Medicare. It's going to go broke by 2026. And total knee replacement is the second most common procedure in the country. What's first?
Heart.
Cataracts. Cataracts. So, and statins cause cataracts, by the way. It's another lecture someday. Okay. So we can't afford it. Traditional beds cost too much. And if you look at it, it costs $50,000 to be in the hospital and have a hip or a knee done. It costs half of that as an outpatient. So if Medicare's going broke, we better figure out how to do it and make it less. And how about this? Is it safer in a hospital? We went over that already, right? But your risk of infection and stiffness is higher if you stay in a hospital. Why? I don't know why, but just don't be there, Is everybody a candidate? Well, I have 90-year-olds that feel like 50. I got 50-year-olds that feel like 90. Okay? So not everybody is a candidate. Like this guy, maybe not a great candidate. I don't know. You have to take some responsibility for your health. So maybe, he's got to stop smoking, get his diabetes under control, eat a few less French fries there. And probably joint camp. Melissa's in the back. She runs our joint camp. It's all about education. Everybody had a knee or a hip done. Their neighbor did. Worst pain in the world. And it's true. 50% of these patients historically had the worst pain in the world. Now, we don't have zero pain, but it's amazing to see people going home 4 hours later. They have no pain that day. Reality, third or fourth day, it hurts a little more, but they're home. It's manageable. I say, don't wear your pajamas. If you wear your pajamas, you think you're sick. No pajamas. Put your clothes on. Remember? Remember that? Remember you had the flu, you stayed home from school, you put your pajamas on, you're sick. You put your clothes on, you go, wow, I could go out now because it's 3 o'clock, your friends are home. I mean, it's true. It's true. It's true. So, it's true. Right? Yeah, no pajamas. So anyway, we've done now over 530 only at Coordinated Health. We have no medical readmissions. We control the pain. And so now I'm going to go on to my last controversial topic, the endocannabinoid system, okay? This didn't happen in the 60s, okay? This isn't reefer madness, okay? This is a system of cellular communication that's been around for 500 million years. This is how our cells communicate. We've just found a plant, the phytocannabinoids, that attach to those receptors and do some of the wonderful things that our own body does, okay? It's like endorphins, okay? So our body has its own morphine, its own opium, okay? We just found a plant that hits those receptors to take care of that pain. So, if you're out on you're out in the war zone and you get shot, you know what? You're worried about living. All of a sudden, your leg's blown off, and you're really not in a lot of pain. You're just crazy. You just can't believe your leg is blown off, okay? But your endorphins are kicking in. These are natural endorphins. That's what opium is. Well, the endocannabinoids are the same thing. Look what they do. They modulate everything in our body. They modulate pain, inflammation, anti-nausea. I don't know if you remember years ago, anybody with chemotherapy in the old days, you got sick, you lost your hair, you did all that stuff. What did they give you? The only thing that would help was medical marijuana. Remember that? Or real marijuana. Because it's an anti-nausea, anti-anxiety, tissue healing. There's no respiratory depression. There's no CB receptors in the brainstem. You don't stop breathing if you smoke too much. We're not smoking it now, we have it in pills, but it's crazy. Do you know how many people die of opioids? We just talked. How many people die of, you drink a quart of alcohol, you die. There's never been a death of overdose of marijuana. But yet, it's a Schedule I drug, the same as heroin, cocaine, crack, that has no medical use. Does this sound familiar? Okay, just like the vitamins, right? So this is gonna come out there. But how about this? The government, the United States Health and Human Services, what do they own?
The patent.
They own a patent. A patent on cannabinoids as an antioxidant and a neuroprotective. So the government knows this, but they get paid by pharmaceutical companies. It's crazy. So hopefully the Farm Bill will go through, and the hemp-based CBDs will be another addition to our multimodal pain approach, so that decreases your anxiety for certain. All this is preclinical studies. Why isn't it out there? Well, there's no studies because we're prevent it from studying, because it's a level 1 drug. You can't do a study on heroin, okay, because it's a Schedule 1 drug that has no medical use. So they've kept it as a Schedule 1 drug, so there's not a lot of basic science. These are all preclinical studies that these are accurate things. How about going into surgery if you could have less anxiety, less nausea, less pain and inflammation? So it makes sense. This is not crazy. How about this? These are all the things that it does at a cellular level because it's been around for 600 million years. This is what it does. It modulates homeostasis in the body. So anyway, and most of these things act on the cannabinoid receptors, things we use every day. Advil, Toradol, Tylenol, Celebrex, they have a cannabinoid mechanism of action. Remember the runner's high? People talk about, well, if I go and run 10 miles, I feel great. Feel this runner's high. They thought it was from endorphins, the natural opioids. It's not. It's from the natural endocannabinoids we know now. So this is a wonderful thing. And you know what? It's derived. Where are they made? Okay, they're not made out in the marijuana plant. They're in your body. They're made from the cell membranes, arachidonic acid. You know what else is made from the cell membranes? Omega-3s, anti-inflammatories. Why are they both great anti-inflammatories? They come from the same place in the cell membrane. And so when you get some of the liberal media now talking about it's time for medical marijuana revolution. So again, a lot of the advantages, like Wayne talked about, are orthobiologics, not necessarily the equipment, but a lot of the approach to medicine to decrease side effects and your pain. And as Ron and Wayne said, we do the highest volume, hard to believe, we're the smallest network, we do the highest volume of joint replacement with the best results, highest health grades. We like being here, we love you being here, thank you for coming out, and I probably talked too long, but that's it.